All right, what I'd like to talk to you about is some patients with MS are being followed by you. And in the follow-up period, normally what we're looking for is the normal things on the afferent and efferent side for optic neuritis, which is the most common cause of afferent disease in multiple sclerosis. And on the efferent side, we're going to be looking for INO and diplopia from fascicular cyst or horizontal gaze palsies, things that involve the central nervous system on the efferent side, or nystagmus. So this is the normal evaluation for an MS patient coming to see me. Is I'm going to do a visual field, I'm going to swing the flashlight, look for the pupillary defect, I'm going to check their vision and their color vision, we're going to do an OCT. This is the normal evaluation. We're going to do a motility examination and make sure they don't have nystagmus, INO, or cyst or diplopia. The normal MS follow-up patient. However, you should know that sometimes we are being asked not to look at the disease, but at the treatment of the disease. And one of the treatments that you need to know about in MS patients is a drug called fingolimod, which goes by the trade name Gilenya. This drug is a S1P sphingosine 1-phosphate inhibitor that reduces lymphocyte trafficking and reduces the inflammatory response of multiple sclerosis by blocking cell signaling mechanisms. Sphingosine, as you know from other videos, is a core molecule, however, and that sphingosine is involved in other activities, including endothelial cells and structural. It's a structural protein. It's in the glycoprotein family from which myelin is derived, and neurotransmitters and other things are derived from sphingosine. So the thing you need to know about with Gilenya is FAME, fingolimod associated macular edema. So we do a baseline evaluation, and you're going to be doing something that you normally would not do on an MS patient. You normally would not be doing a spectral domain OCT of the macula, but in patients who are on this particular agent, we are going to do that. And 3 to 6 months later, you're going to repeat this study to make sure that they do not develop FAME, fingolimod associated macular edema. It otherwise looks like macular edema. And as opposed to the other forms of macular edema where there's vasculopathy like diabetes or hypertension or something wrong with the blood-retinal barrier, these people have localized disruption in the macula. They don't really have any other retinal vascular abnormalities. There's no hemorrhages. It just looks like macular edema, but it's medication induced. So you need to look for FAME in patients who are on fingolimod in MS, and that means doing a little bit different, a little bit of extra work on the front end. And if they complain about vision loss and they're on this agent, you need to do a macula exam and a macular OCT to make sure that the vision loss isn't from FAME. Otherwise, you're going to think that it's afferent optic neuritis from multiple sclerosis, and that is the disease and not the treatment of the disease. And you need to be looking for the side effect of the treatment of the disease.